Good morning. This is I'm gonna probably take a slightly different course here, but I thought this would be an interesting discussion. I think many of you know that I work with my radiology hat on. I'm working with the ARC on some different imaging protocols, and I'm also pretty passionate about communicating with our radiologists, but we need to understand what we're a little bit more about what they do so we can talk with them well. So this is kind of a very quick look at MR evaluation for cerebrovascular occlusive disease. And the names on here, obviously you all know Dr. Penho and myself. We have a R01 with Hang Zhang Liu and the group over at Johns Hopkins. Actually, Pei Ying Liu has moved to University of Maryland. So now we've got 3 different centers that are working on some of these techniques and applying them to cerebrovascular occlusive disease. Disclosure wise, there you go. Nothing really pertinent. I think a few safe assumptions that kind of got me interested in this. I think we're so beyond what moya was meant to describe, and a lot of people, I try to catch myself. I use moya as a term, but also I talk about cerebrovascular occlusive disease in general, because everyone knows that means puff of smoke, and that's just a bad angiogram at this point. There's so many different etiologies of this occlusive disease that have different pathways to the same picture. And so I think understanding a little bit more in the image acquisition and optimizing what we're asking for to help our procedures, that's our job. So what I want to do here is just give a little brief explanation of the MR terms that are useful for us, and show some opportunities about understanding this pathology. And at the end, I'll share a little bit about some of the research that we're doing. So why do we use MR? We want to refine our understanding of the anatomy. We want to identify the tissue that's affected by this disease. We also want to understand the altered blood flow effect produced both dynamic and as well as resting. And then really look at the tissue that we're working on. That's our job as surgeons. Why don't we use MR? We kind of know these: the time it takes, the metal restrictions, the patient claustrophobia. Just as a little side point, the radiologist, most patients can tolerate about an hour and a half. Once you start getting up to about 2 hours, that's when we get some resistance in terms of the number of studies we're asking for. I think our need to understand the bony anatomy means MR makes it a little bit difficult. That's why we get a lot of CTs and MRs. And then obviously the contrast application, some of the sclerosis side effects to constant gadolinium administration have been purported, and that's why probably over the last 10 years we've seen a lot more restriction on renal clearance and even gadolinium. But more recently, the metal restrictions that came up, even yesterday in our providers meeting for stroke, we talked a little bit about trying to get rapid stroke protocols done in patients who had pacemakers and things like that. And even though most of the devices put in are MR compatible, this MR conditional that we see on all the cards and devices that we use, MR conditional means if all the conditions are met, it is MR safe. That's a little bit different than you can get an MR because you get a card that says MR conditional. And in the case of the pacemakers and things like that, our biggest hurdle is actually we're very rep dependent. So from 8 to 5, you can probably get a MR done on a patient with a pacemaker, but after 5, and we all know strokes happen after 5, it's a little bit more difficult. So that's something we're working on with our neuroradiology. We've got a stroke group that meets about this. So an ideal study would be something that's short, something that's not restricted by metal, something that is open. We know we don't love the open, but clarify bone and tissue relationships, and then a little bit less reliance on contrast. I think I'm not sure we'll get all of this, but if we communicate with the neuroradiology team a little bit better, I think we'll get our part more successfully. And so I think a better pre-procedural MRI evaluation probably would have helped a lot of our pivotal studies if we were really using MR more often. This slide here just gives you some terms that I'm going to kind of refer to. There's obviously plenty of YouTube videos and antiquated textbooks that can talk about this. But when we talk about pulse sequence, you're talking about that magnetic hit that consists of it's a radio frequency pulse that's delivered, and then the radiologists and the algorithms are looking at the alteration and then the return to normal of protons in the brain, in the tissues that are being evaluated. There's this repetition time, which is the amount of time between the pulses applied to the same slice. And then there's time to echo, which is the time between the delivery of the pulse and the receipt of the signal. So this TR to TE relationship is really what gives you what's in the figure there. Your T1 weighted, the T2 weighted, and T here doesn't mean Tesla, right? T here means time. And then one of the things that, we get a lot of flares in T2s, but those are probably the longest, pulse and evaluation, pulse and evaluation. And that's what you can see on that lower part of the slide. So just so we know that we're very fortunate here in terms of, being able to get what we want. But you'll see the radiologists are a lot more sensitive to the time it takes to acquire the sequences that we asked for. It's almost like, hematology and blood products, right? We just want the blood now, but then hematology is controlling that resource. And I think the better we understand what we're asking for, we can utilize our resources a little bit better too. So FLAIR, this is fluid attenuated inversion recovery, right? So you're the whole inversion recovery sequences is you're altering it and then you're bringing it back. And this is fluid attenuated, which means that basically it turns the CSF dark, right? So there's your T2, and then there's your FLAIR. Now T2, the term used here is null, right? So you hear that a lot. So a FLAIR nulls CSF and a STIR nulls fat. And that's all depending on the tissue response and the return of that tissue to that more normal state. FLAIR is kind of an older term in terms of what we get. We probably get T2 flares more often, and that's what we're typically looking at. But it's just improved algorithms that we can use. So the DWI, obviously we use that a ton, right? And that's looking at water moving through water molecules moving through tissue or uninjured tissue, right? So low diffusion occurs in highly cellular swollen tissue, but we always need to interpret the DWI, and you'll hear us talk about it in vascular conference all the time. What did the ADC look like? And then you see these if you look on your sequences. A lot of times we're jumping to a DWI, and all the residents are looking through the sequences. These are these B value sequences. So this is kind of a B0, and you'll see a B1000, and a B1000 is probably a little bit closer to the DWIs that we look for. So if you're looking through sequences from other places, a B1000 is close to a DWI, but you want to make sure that you correlate that with your ADC. And I'll make a comment here that a lot of the terminology that's used is vendor dependent, which is really annoying. But if we know the kind of the background of it, a B1000 and a DWI, depending on which vendor you're using, is a helpful understanding. So perfusion, a lot of these, it's just various techniques that give insight into the perfusion of tissues and blood. So, we use it to understand ischemia, vascular reserve. This dynamic susceptibility relies on the contrast and then that T2 signal. The problem there is blood and calcium kind of make it difficult to evaluate. This dynamic contrast imaging it can understand T1 shortening changes. And we've heard a lot about this K-trans. And this is a very unique way of looking at diffusion almost through tissue. K-trans in the cerebrovascular world is actually a guy that used to work up there with, these are guys from Northwestern. They're looking at, diffusion of or inflammation around the wall of aneurysms and potential diffusion of liquid that suggests that an aneurysm is ruptured or not ruptured or weak or not weak. So this K-trans, for some reason, the K-trans just really hasn't caught on a lot of places. It's been around, as you see, this is from 17, but it's been around even longer than that. But I think we're looking for ways to tell if aneurysms have ruptured or not, and this K-trans sequence is one of those. So what you're going to be hearing a lot more about, I think, is this arterial spin labeling in MARC perfusions. And the reason that arterial spin labeling is helpful is that it really doesn't, you really don't need contrast. And it's being used more and more, but it has some limitations similar to CTA. So it's based on the fact that you label something, so give me a CTA. A CTA, you get the contrast in the artery, you measure the time to the vein, and then you take the picture, and how many times we see venous contamination related. But the same thing with arterial, you label inflowing arterial blood protons, and then you watch those protons go through a picture. There's a certain amount of time depending on an adult or a child. There's no contrast, but it is somewhat time limited. And so that's the one thing that you're still kind of working on. But if you realize that radiation is not an issue, your main limitation is scanner time. So if you miss it, you could always go back and do it again if the patient is calm and you're not exposing them to more radiation. So there are definitely some pluses. There's a multi-delay, which is very similar to multi-phase CTA, which we use for our stroke protocols. But again, study time and scanner time is the issue. We've got 5 scanners in the hospital right now, so we're a little bit more open to more scans as long as we can communicate that with our radiology and our radiology techs. So we talk a lot about vessel wall imaging, and I'll give some examples here. There's a lot of advances there related to now this is 3T Tesla, right? So 3Ts are pretty common for us in the community, not as much. Those are 1.5 Ts. We have 7T scanners now, which we use for research. They've been over at the ARC for years. There is some clinical use, but usually only under protocols. What you get from a lot of these higher res CT scans are orthogonal reconstructions, so you can look at these in multiple angles. So you can end up with something like this, right, where you've got your looking down the pike on these vessel walls. This is what you get off of an MRA, but if you do a vessel wall protocol and actually go through, you can see a lot more detail. You can understand the wall. I think an argument could be made that the Sampras study that really dictates a lot of how we manage intracranial atherosclerosis. I think that there's patients who were less than 59 with risk factors were involved, but you could have caught a compensated moya patient, right? And had the same, and then we know that stenting moya patients is not something that is going to be successful, and that may have affected some of the Sampras results. One comment on the terminology: when we talk about vessel wall imaging here, a lot of times we're using these VISTA sequences. When we refer to it in the clinic, we call it, I've been calling it the Pinhole protocol, because Marco and I worked on making sure that this is how we're protocoling these studies. But VISTA sequences are the Phillips. Siemens has another term, and I honestly can't remember that, but kind of differentiating between dissection, atherosclerosis, vasculitis. Those are all things that I think are helpful if we're going to do the vessel wall. This is a good look at a patient that I cared for. We know him well. We saw him recently with a proximal vert stenosis, for those who are familiar. And here you're seeing his vessels, in a coronal view, but this is intraoperative look at the intracranial with the athero. Now this is a guy that if you made him a little bit younger, you could call this some moya disease or occlusive, but that's clearly atherosclerotic disease intraoperatively. So just another example, same gentleman, and that's the imaging that we see on the angiography. But now we've got different ways to look at it, and frankly, I would argue that a good vessel wall image with some dynamic imaging would get me to a point where I may make some decisions on the patient without the angiogram. A lot of times, I'm also using the vessel wall imaging for these vertebral basilar. We get a lot better pictures. I think it's because we're able to kind of catch a longer segment of the verts and the basilar, and look at it. This is a gentleman who had initial imaging. You can see the thickening of the wall. What I'm showing you here is contrast and non-contrast enhanced. Right, so there's some argument that moya patients have more enhancing vessels, but this is a clear atherosclerotic patient with posterior circulation disease, and you can see the enhancement in the vessel wall as well. So that's not the end all. That's not as much of a differentiator, I guess is the best way to say that. These are the orthogonal views of that same patient. And the comment I'll make here is a lot of times we talk about patients with immunopathology or potentially moyamoya disease, but being more concentric, like this E image here. But this is a atherosclerotic patient who has some concentric, but also some eccentric narrowing of the vessel. So I think we would need to see that a little more uniformly along the vessel to call it not athero. This is actually a moyamoya patient of ours from one of the articles that we published, and you can see that this guy was 27. He has a history of a right MCA stroke, and you can see on the MRA that red arrow there is pointing at where the stenosis is. The vessel wall imaging that we have here allowed us to kind of see and trace the vessel through. And then on the lower image E, you can actually see that cross section where we see the narrowing of the MCA. And so again, I can take these images, I can put them on this Osiris program that I use a lot, and we can do a lot of reconstructions and moving around and looking at the vessels. So we get a lot out of this. And these are 3Ts. The difference between a 3T and a 7T is a 3T really gives you good, excellent, proximal, maybe M1 and more proximal anatomy, whereas the 7T will take you out a little further, maybe out to the M2s. But not much more than that. So I think that may be why, that and the device compatibility, et cetera. I did my own 7T MRI as we began this study, and it's quite the magnet. My tricep was jumping when it was throwing pulses at me. So it may be uncomfortable for the patients. So the pitfalls to the vessel wall imaging, I think, are these: the flow voids and contrast enhancement, just like everything else, can be affected by the slow flow. And then you can also kind of miss. So you get venous structures that may be interpreted as arterial enhancement. And these are some images on the right that show venous structures enhancing. And that's because of the slow flow. The pulsation can increase the size, increase in the cistern. So we get a pulsation effect as well. And that can throw things off. So, but there's a lot of, if you talk with the neuroradiologist, there are ways to, if you say, I'm looking for a vertebrobasilar vessel wall, there's some things that they can do to take out the pulsation effect. This is another gentleman that we did some imaging on, again, giving a similar look at the vessel wall. The point here on this slide is that if you look in E, it's a little bit of an understanding. Look how much better you can see this narrowing here, or the occlusion here, on the contrast enhanced images, which are below, versus the non-contrast images, which is in the upper panel of E. So a contrast enhanced vessel wall is, you're pretty much going to get that. And so when we ask for that protocol, that's what we'll get from the clinics. Again, examples of the slow flow and how that can make things look, it can throw you off a little bit, but these are veins that are enhancing, not arteries. So the vessel wall, really the high resolution imaging is very useful for that proximal structure. And as I talked about, the 3 and 7T are for what we're looking for, pretty close. But the contrast enhancement, I think, would be helpful. And so I think we've pretty much gotten there in terms of doing that through the protocols that we use from clinic, and even in the hospital. We can get these inpatient. The arterial spin labeling, MR perfusion is coming. I've talked about this a little bit, and so just some examples of what we can see. The lower frame there, the color frame, is the baseline and Diamox ASL. So that's very doable, and you're starting to see kind of an uptick in our MR perfusion. But one of the things that I just wanted to kind of end with, which is a newer technique, is this MR fingerprinting. And this is a concept where you can actually look at, in a single acquisition, you can look at you can get multiple parameters that we're interested in. because it's not acquired randomly, you actually have a certain pattern that the MR can pick up, and then that pattern is matched to a predefined dictionary that they have, and then based on that pattern, that fingerprint, you can then say, look at CBF, cerebral blood flows, cerebral blood volume. You can do all of that in one sequence, and that's what's helping us in some of these patients and these research protocols get more information over a shorter period of time. So this is one of the papers we published on. At this point, we had about 32 patients imaged, and over a 3-minute scan, we were able to get CBF, bolus arrival time, and pass through all at the same time. And what we're doing over at the Advanced Imaging Research Center is evaluating patients who go through baseline image, cerebrovascular reserve imaging. I use a lot of SPECT. We're using CT perfusion as well, but then we're comparing that to a CO2 protocol. When the patient puts on a mask, they're slightly hypercapnic, and then we can see the cerebral blood flow change. And on this is some of the data from our initial group of patients, but a 57% increase in cerebral blood flow in normal patients who were not challenged. So what we're doing now is looking at an hour and a half. We can get MR, MRA, vessel wall imaging, and pre and post inhalational studies, and that's pretty decent that the patients can get through. We've had one patient that got dizzy, but as I've told many of you, she was kind of dizzy before, so there's not there really hasn't been any side effects from that. So this is the imaging protocol that we use. So initially we get MR for the patient. So we get the MR with and without, MR Nova, SPECT or MR perfusion, CT's in here as well, angiography. That's the patient. These are Moya, and now we're doing intracranial afterflow patients that come in. Then if we have no bypass, we do 6 months yearly, 6 months yearly, and then an MR Nova, and then we do follow-ups. The bypass, we do the same thing, but we get an evaluation 3 months post bypass. Interestingly, in our group, we have more bypass patients. They don't do direct bypass at Hopkins, so we actually have a pretty internal group where we can look at the results in patients who have indirect bypasses versus direct bypasses here. So our goals right now are really getting shorter and more accurate imaging evaluations in patients with disease. I can't impress upon everybody enough how important it is to talk with the neuroradiology teams to get what we need. I'm encouraged that the CO2 protocols might be helpful. We had a little hiccup with COVID because they were concerned about inhalational studies, so we actually had to do some breath holding protocols, and so we'll see how that affects our data. And it's good. We've got multi-center involvement right now. We're trying to bring University of Maryland on board, but with Hopkins ourselves, we've got a decent group of patients and a nice flow going. So I'll stop there. I hope that was helpful, and will help us communicate a little bit better with our people. So.
I have a question, Joe.
All right, thanks, Babu. We got a couple of questions.
So I was involved in an experiment in intracranial patients where we had them breathe CO2 in order to induce a state of severe anxiety, looking at a model like OCD and some other types of things. It really, it's like gives the patient a sensation that they're about to die. Does that happen for these patients? Or not really?
Well, so yeah, that's the problem with because you can imagine putting them in a tube and then saying, "Hold your breath, ma'am." Right. Yeah. So that's what I'm worried about with unfortunately, we had kind of a lull, so there weren't that many patients that we had to do breath holding on. But in this case, we're actually they have a mask, and we're turning a valve where they have they're inspiring more CO2.
That was the paradigm I'm talking about, more so than the breath holding. You haven't, I mean, maybe the numbers are different, but it was, I think in our protocol, it was 10% CO2 induces feeling of asphyxia, even though they're not in any danger.
That's why we got to the 5%. I think initially they were dealing with, they went through 5, 10, and 15. And 5% gave us the effect that we needed radiographically, but didn't have as much of a.
I see. Yeah. But I mean, if you have a protocol for this, you guys could potentially take advantage of it to see, like, to get some physiological signal related to this if you're interested in anxiety. The related question, so you have, this is a study that's a group out of Hopkins, and what I'm just trying to understand, just from like, for thinking about matching medical students or residents with research interests, what is the central innovation in the grant or in the project?
The real thing is evaluating these. The real thing is to evaluate the inhalational protocol and how it corresponds. Frankly, we're also using a lot of the data that we get to evaluate other MR techniques. So the initial grant that I got was a St. Paul Foundation grant years ago to look at MR techniques in cerebrovascular occlusive disease. But then when Hang Zhang and I got together, and he was also looking at things, so that's where the R grant came from. So it's really techniques for cerebrovascular disease, but what we've been writing on a lot is the MR fingerprinting and ASL techniques for this disease. Does that help? So yeah, so if there's an interest from a student standpoint, for Moya in general, would be one option, because there's plenty we've got a whole database on that that we keep Jennifer Ocon keeps that pretty up to date, and then we have looking at the other parameters that we're collecting, because we have done nothing at this point with the vessel wall imaging that we've gotten on all the patients. We've been focusing on the physiologic data.
All right, interesting. Any other questions?
I just have a general comment for the residents mostly. So this is a talk about imaging cerebrovascular disease. I can tell you in my first year here, I've spent a lot of time looking at imaging. Did the same thing at UCLA. The brain tumor group, I can guarantee you, has spent a lot of time working with radiology. So it's something you shouldn't take for granted. Wherever you go, even whether it's a private hospital or an academic setting, don't take for granted that the imaging is already optimized. It's something you really need to work on, because you rely on it so much that it's worth the time investment to at least get it up to a certain level of standard, if not trying to be innovative like what you're hearing here. It's a really critical part of our practice.
And so Andrew's exactly right, but just to echo, you can get radiology, you can have them give you the actual protocol for the scanner and how they're running each of these sequences. And you can take that with you in a giant binder and give it to your new location, especially if there's sequences you care about. It can be a different scanner, it doesn't always work, but it's a place for them to start to try to.
These are really, there's still a lot of room at ARC for stroke-related studies. The only studies that were done prior to this one for neurosurgery were the brain tumor studies. So this is really the first stroke-related study that we've had at ARC. There's a lot of room there for that, but there's also the interest. We've got people we can work with now that we didn't have before. So there's definitely opportunities.
Yeah, all right. Thank you, Babu. I appreciate that.